This is Case of the Day. I'm Dr. Bhavin Jankaria, and today we are looking at the 115th case, and it's titled Nodes, Nodules, and Biopsy with Hydrodissection. 49-year-old had fever, had a CT which showed some findings, came for a PET CT, and the PET showed non-necrotic enlarged lymph nodes which were active. That's the pattern of distribution of the nodes on the coronal PET, which resembles a lambda sign. Um, and the lung windows accompanying the PET were of poor quality. So this was sent to me for a biopsy. And so after the biopsy, I repeated an end inspiratory scan that shows these fissural perihilar nodules. The fissural nodules are so much better seen on the coronal and sagittal images, and you can see them better on the 3 millimeter MIPS, and they're beautifully appreciated here. In fact, there were some perivascular nodules as well. She had come for a CT guided subcarinal node biopsy, which I did. So here is the subcarinal node. I couldn't see it very well initially, so I did a 7.5 degrees craniocaudal angulation. So now there is a clear path to the lymph node. So using a 20 gauge Cook needle, I placed it first next to the foramen, injected local anesthetic. You can see the space that has been created, pushed the needle further through, injected a combination of saline and lignocaine, created even more space, then into the lymph node, pierced it, withdrew it a little bit, deployed only a 5 millimeter of the gun instead of 10 so that I wouldn't overshoot, and that's the biopsy through the subcarinal node. The summary here, the size of the node was 13.2 millimeter z-axis, and often this is considered not abnormal. I mean, routinely up to 15 millimeters subcarinal node short axis is fine, but this was part of a constellation of lymphadenopathy, and therefore it was abnormal. 2 cause for histopath, 2 for micro. It took about 12 minutes. The only issue was, and in fact, it took 2 minutes more because when the needle entered the node, I think the node was probably a little stuck to the main bronchus, and there was a lot of coughing, which normally doesn't happen. And this was done today, so we don't yet have the biopsy result, and I'll update it in a post and on the site when the histopath report comes. But the expected report is non-necrotizing granulomatous disease of indeterminate etiology, which is what the histopathologist will say. But what do we have? We have a combination of non-necrotic nodes and perihilar fissural nodules with a lambda distribution on coronal PET, which is classic of stage 2 sarcoid. And these are the stages of sarcoid. I had done a lecture at ctchestreview.com, and you can see here stage 1, nodes, normal lung, nodes, abnormal lungs, nodes not present and abnormal lungs, and then fibrosis, which is stage 4. And in stage 2, you can get different forms of lung lesions. Now, classically, we see perihilar fissural subpleural nodules, but here we've got a nodular reverse ground glass, kind of ground glass in the center and a nodular periphery. Or you can get these cluster and galaxy signs that have been described in this patient who has non-necrotic subcarinal and hilar adenopathy. The other issue, of course, is that as EBIS is becoming more and more popular, the referrals for subcarinal node biopsies are diminishing. 15 years ago, 20 years ago, we used to perform 2-3 procedures every week. Now maybe it's once in about 2-3 weeks, depending on the person referring. So senior pulmonologists and MD physicians would refer cases, but the younger pulmonologists will do their own EBIS guided biopsies. Having said that, radiologists are therefore not learning this skill. It's not difficult, but you need to learn how to hydrodissect, how to find the path to the subcarinal node, and we shouldn't be giving up. It's still a safe, simple procedure, and there is no reason why you can't have 2 or 3 competing procedures available for the same node or the same area to be biopsied. Just as you have ultrasound guided, CT guided in the liver, or in the kidney or the pancreas. Similarly, you can have EBUS guided and CT guided for the subcarinal nodes. And for those of you who want to read more, at ctbiopsy.com, I've got multiple cases with hydrodissection in the mediastinal lymph nodes. So while stage 2 sarcoid often will have classic findings, you still need an appropriate nodal or lung biopsy to confirm the diagnosis. And a CT guided subcarinal node biopsy is still a good option as compared to other modalities, including EBUS. So just remember that. My WhatsApp channel. Thank you so much for viewing this.